Thank you so much. Good morning, everybody, and welcome to the last webinar of this series. I'm so happy to be joining again. And again, I want to really thank the cultural responses of Academy and Max and Charmaine is present today just for the support and the passion and really the call to action to just create awareness. I'm so excited to be doing this webinar. And so I really just want to get into it because we're building on the first and second one. If you missed that, I'm not really going to review a lot of what we talked about already. This is building on those two webinars. We're going to talk here about really more about just how TBI might be showing up to you and what can be done about it. So let's get started, everybody. Welcome again. I just want to go through just the content warning. Again, this is a disturbing content. We're going to be talking about domestic violence, traumatic brain injury, non-concussive head impacts, as opposed to concussions, and progressive neurodegenerative diseases like chronic traumatic encephalopathy as they impact women, men, children, and youth. So I encourage you to practice self-care and just give yourself some space as we listen to all of this information. And again, like Max said, at the end, we'll have Q&A. So the learning objectives is to really briefly is to provide historical reasons why DV-TBI victims and survivors are undiagnosed and untreated and really being provided with minimal care, to demonstrate an understanding of how the overall current health field can be improved to serve DV-TBI victims and survivors, explain how the system of care can screen and better serve DV-TBI victims and survivors. And then we're going to get into a little bit of analyzing the intersectionality forces of health and disparities that further isolate racial and ethnic DV victims and survivors from receiving care and services for their TBI and CTE kind of conditions. We want to also discuss the opportunities health services has to screen and serve the children, youth, parents, families, kin, and communities impacted by this, what I consider a pandemic, but in the United States is considered an epidemic. So we believe that everybody has a right to receive care. So women, men, and children and youth living with DV-TBI and DV-CTE have the right to receive and have access to proper and needed behavioral health and health care. And I want to get into a little bit at how might some of the DV-TBI and DV-CTE symptoms present to providers, just to give you a little understanding, a little taste of it, just an overview. So you may notice illegible handwriting, some slurred speech, speaking too slowly, quickly, or too softly, difficult hearing or seeing, very distracted, and I mean very distracted and bothered by light and noise. And they're not going to tell you about these things, right? There might be a little paranoia going on. They may seem withdrawn, a little bit more intolerant, tired, confused, inability to understand words, inability to use a hand, difficulty reading, finding words, expressing ideas, or getting to the point, poor listening, short attention span, overreactive, impulsive, defensive, anxious, nervous, and unable to focus. And again, these are just some of the symptoms that might be presenting to you. And just a little bit of the historical reasons why DV-TB and DV-CTE victims and survivors are not receiving proper care and needing care is we're going to go through a little bit historical, gender, race, and other reasons, intersectionality, lack of cultural responsive services. Most victims seek support from informal systems and the gaps in the system of care. So brief overview, I just want to go through this really quickly. Just historical and gender reasons that have resulted in the system of care and brain science largely failing to address this epidemic among the domestic violence population. In webinar 2, we talked about the white male model as a standard for health in the medical field. So often other populations and women are neglected in research. So there is inherent biases that remain to today. So we just have to be aware of that when we are reading research and science on this topic and other topics. The domestic violence services, I think there's challenges and opportunities that we can look at. I think the field has done a tremendous job doing great work. Many women, children, men, and youth, and pets Having run shelters myself, domestic violence shelters, we serve pets, have been served. Historical roots based in really meeting the basic needs of really continue to be also the primary focus, which meant women fleeing homes where they were being abused. Racial and ethnic women have largely been unserved, and that challenge remains to today. And then there is lack of cultural and community responsive services within the domestic violence field. I think some of them are doing a better job, but I think it's still a difficult and a challenge that they continue to want to address. So just a really brief history of the battered women's movement here. It started in the 1950s and 60s and encouraged activists to publicly discuss DV and call for measures to protect women. At the time, the public assumed that spousal battering was rare, so few survivors spoke about it publicly. Most women at that time and wives really tried to receive services and sought help from their churches and priests, and really were told to be better wives and be more obedient and just pray for their husbands to stop beating them. Many just suffered alone, sometimes telling family members and close friends, and some, as you probably can imagine, were murdered. Then we have the Better Women's Movement, the 1970s, that really started taking, it just became birthed. There were more official shelters that were opening, and really advocates were documented as actually taking survivors to their homes to, give them respite and protection. And they knew that the most important factor in escaping violence was to provide safe shelter. So efforts focused on creating DV shelters and housing solutions. So 1974, there was the first shelter that was opened. By the 1970s or end of the 1970s, there was at least 250 shelters across the country. In the early shelters, this again provided primary services to white women, focused on physical injuries and emotional aspects of both violence and leaving the relationships. They really helped them with, just difficulties escaping violence and living in unfamiliar surroundings. Children often arrived with their moms and their mothers. So there was legal and basic social and medical service that were needed, but primarily it was housing and then trying to find services to provide for the other things. Significant progress has been made. Obviously, we've done lots of really wonderful work. DV initiatives aim to increase public awareness in the creation of printed materials, so really getting materials out to women about this issue. Issues of race and ethnicity, among other concerns, were raised in the United States in response to the limited engagement of DV shelters with diverse race and other groups. So it still continued, as you get to see. The challenge was, how do we serve everybody, right? So today, according to the National Network to End Domestic Violence, they do an annual count. So they get this information every year. There are under 2,000 domestic violence shelters in the US, but that does not reflect the informal and private ones, that are sustained in this country just by individuals wanting to support this issue. But if you think about it, under 2,000 for the entire country, you think of how many women, children, and men are victims of domestic violence. Shelters continue to struggle with having enough resources. Length of stay is a critical issue to be mindful of if we think about how long it takes a brain to just recover from one traumatic brain injury. And for women and children and youth who are sustaining traumatic brain injuries in homes that are because of domestic violence, there's multiple types of brain injuries happening. But the limit is 30, 60, 90, or 80 days. And if you're fortunate, you might get transitional housing, which is up to 2 years. Then there's the rapid rehousing, is intended for individuals or families with moderate acuity and offers co-occurring financial assistance within 30 days of getting permanent housing, with limited case management assistance, typically lasting 4 to 6 months and extended up to 18 months. So you think of that, and we're going to get more into like how long it takes the brain to heal. It takes a lot more sometimes than 2 years, especially if you're having a lot of trauma in the head. So adolescents are usually not allowed, nor family pets. So women have to think about, and men who are abused have to think of what happens to children who are older and what happens to their pets. And so just a quick overview of what, again, what are we talking about? What is the estimate of the domestic violence population? This is just a little repeat from webinar one to give a context. 12 million adults every year on average, and over 24 people a minute are abused per minute in this country. Research estimates that between 3.3 million and 10 million children are exposed to domestic violence every year. And there's a lot of reasons why the prevalence is so wide, lots of reasons. Researchers estimate that 10 million teenagers are exposed to domestic violence each year. And then we have a disproportionality of domestic violence in marginalized and disenfranchised communities. We have to be mindful that 70 to 75% of DV victims never speak about domestic violence or seek care. So just be mindful of that. And so at a glance in 2024, I thought I'd share this information with you. Again, it's a one-day unduplicated count of DV services requested and received across the United States. And of the under 2,000, 1,626 programs participated. And it included close to, I'd say about 77,000 victims that were served. About 48,000 were adults, and then we have about 29,000 were children. And this is what they said was primary top services. And so I put them in chronological order. As you can see, shelter is really critical, children advocacy, legal services, again, services related to housing, mental health, public benefits, really important, in therapy and counseling for adults. It's also important to see what went unmet. There is a reduction in funding going or being allocated to the domestic violence field in this country. So it's really interesting. The highest unmet need was housing, but look where the cuts were. 172 motel stays, 87 transitional or other housings, and 74 emergency shelters were closed across the country. And it's the funding is being cut. I think with this administration, that's going to continue. So that's probably going to just increase. So unmet needs, 13,000 requests for services could not be provided for. And again, the majority were for emergency shelter, hotel, motel, transitional housing, and other types of housing. And again, many programs struggle to maintain stable funding, forcing them to reduce services, laying off staff, and denying desperately needed services to survivors and their children. Then we have the lack of culturally responsive services within the DV programs, which are documented in research, and myself, having served many individuals and having run very large domestic violence shelters. Immigrant women, although the law says, anybody who comes to a domestic violence shelter needs to receive services. Routinely, immigrant women are not served by domestic violence shelters because they don't speak the language. So that's a concern that we have. Individuals working with the DV field often replicate the subordination and marginalization of marginalized women in policies, priorities, or strategies of empowerment that either elude or wholly disregard the particular intersection needs of marginalized DV individuals and groups. Marginalized women are routinely blamed and subsequently punished for the abuse. Immigrant women and other marginalized DV victims often leave DV services due to feeling disrespected and misunderstood. That was something that happened to me as a CEO. I would often have marginalized women come and speak to me and tell me why they were leaving. So it's just a continued challenge that I think the domestic violence field is constantly facing. And so we want to go over just a little bit about the DV theoretical models. Feminist theory, or the feminist model, it aims to understand violent relationships by examining the social cultural context in which these relationships occur, and views gender inequality and sexism within patriarchal society as a main cause of DV. So we have that theory. Then we have power theories that says the origins of violence are rooted not only in the culture, but also in family structures and dynamics. That's another one. There is many others. I mean, we could spend probably a whole webinar just going over lots of the theories, but these are the primary ones. Overall, current theories have found some level of support within empirical research, but the extent to which these models have successfully affected DV prevention and treatment programs has been very limited. Current DV theories fail to adequately capture and address the complexity of variables involved in domestic violence. So lots of opportunities. We're still trying to understand this issue. And so I wanted to go over some of the domestic violence practice models in relationship to the discussion we're having about domestic violence and traumatic brain injury and CTE. Many DV victims have been helped. Like I said, I just can't underestimate that. That is phenomenal work has been done. However, they do not factor TBI and CTE across the field at all. The different models, a didactic model, the cycle of violence, parent control, the I3 model, survivor-centered models, none of them are accounting for what factor does traumatic brain injury and CTE and these other progressive neurodegenerative diseases as a result of domestic violence, or that they're bringing them into because of historical reasons, as we discussed in the first webinar. What factor does that play into this issue, into domestic violence? So programs for individuals with abusive histories, like my father, many individuals, again, have been helped and supported, but they too do not address the domestic violence TBI and in DV-CTE that some of these individuals might be experiencing. And I literally just had conversations with what's going to be done to incorporate that into these better prevention programs. It tends to be a one-size-fits-all model and mentality. Minimal oversight and evaluation happens with these programs. Minimal impact on reducing DV. That's what the research has historically shown. Most participants do not complete the program, and there are no consequences for that. Violations are not reported to the court. No significant escalating consequences I just shared. There is one promising model that is in Colorado, and it's called the differentiational treatment model, which they try to screen abusers or individuals, with abusive histories to see what programs and what services they need. I don't know, though. I've been trying to get a hold of them and to ask them if they're screening for traumatic brain injuries and progressive neurodegenerative diseases. Then I really want to get into social determinant of health, health inequities, and health disparities as we talk about this population, because it's so critical. So social determinants of health, health inequities, and health disparities are key concepts to understanding DV-TBI and DV-CTE victims and helping us to help them get care. The underlying factors that contribute to health inequities among this population too. So really quickly, social determinants of health are non-medical or social conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. They are out of people's control, but healthcare and system of care providers, as well as community stakeholders, can help people access resources as healthy, so that they can be as healthy as possible. So research has found 5 domains that highlight multiple social determinants of health factors that influence access to healthcare for women experiencing domestic violence. This is just on women, not necessarily on men who are also experiencing domestic violence. And one of them is appropriateness. So appropriateness refers to the adequacy of the system of care to provide the person's needs, such as the person's ability to engage with services, the information provided to empower a person, and the person's capacity to follow through with treatment required. And I mentioned capacity because we're talking about traumatic brain injury, and you will now understand what happens to the brain when you've had multiple traumatic brain injuries. So, of course, for positive determinants of appropriateness, appropriate health determinants is culturally safe programs with women with lived experience. Then trauma-informed consultation is really important for having positive experiences. The negative kind of appropriate health determinants that influence access to care is the medical terminology and health literacy of women with learning difficulties, long emergency department visits, difficult for women with children to, kind of wait there, lack of police and hospital collaboration to provide safe spaces for women, Factors tied to insurance may preclude confidentiality, and then secondary victimization experienced by women presenting to the ED departments and other, healthcare providers. Approachability refers to individuals needing to a service to have knowledge that it exists and have the ability to access it. And I think that's really critical. Do they have the ability to access it? So for this one, we have positive approachability health determinants that influence access to care, which is cultural safety, such as health professionals' friendliness, warmth, supportive, and empowering attitudes. So how we present as providers to them, relevant and needed information provided. What do I need, and are you hearing me, right? This is what I need. You're sharing all this other stuff. This is my emergent need right now. Then there's a negative approachability health determinants that influence access to care. So fear of disclosure, as we talked about, for example, fear of disclosure that by doing so that they're going to lose their children, or their visa status, right? Health literacy and retainment of verbal information, women feeling overwhelmed and having lack of information about services as well as human and legal rights, non-English speaking women feeling more isolated, inability to perceive need due to the nature of abuse, depression, substance abuse that they are experiencing. Again, traumatic brain injury really impacts your ability to see things clearly. Mental health stigma hinders ability to reach out for help. And then acceptability of a service refers to the professional value and culture in an organization. So again, how does the organization make a individual feel of domestic violence population? So positive kind of factors that are associated with it. So health professionals' provision of choices to empower women to decide, right? Not telling them what to do. So negative ones are fear of being judged by health professionals, lack of special support for disabled women, inability to seek healthcare due to stigma of abuse and shame and denial. We talked about that in webinar 1. Racism or mistrust of white healthcare services not respectful of cultural needs, services not accommodating women with children and pets. Then we have affordability, which is a huge one, right? Affordability refers to the cost of services and treatments related expenses against an individual's income, insurance, and overall ability to pay for the care that they need, which is really important. So positive ones, obviously, it's a woman's ability to afford the referrals that are being made, have access to medication, treatment, insurance, etc., ability to pay for medication, right? And ability to do that overall. So the negative ones are the opposite: lack of access to medication, treatment, or care due to losing or no medical insurance, inability to pay for medication, lack of consistency with mental health professionals, as many rely on free services or the health profession overall, behavioral health too, limited patient provider times due to health insurance models, and then poverty barriers. Availability is another social determinant of health that was linked to domestic violence, women ability to access care and get the care that they need. Refers to geographic location, allocated time to address complexity, wait times and hours of health clinic. And I think of many areas that we work in, how some communities are very large, very dense, and there's lack of access to immediate care. So positive determinants of availability of health are influenced by services within a geographical location. If you live close by, that's, you're more apt to go and get care. Have time to address complexity, wait times and hours of the clinic or healthcare facility, access to mobility, billing, transportation, right? You have a phone and computer to make appointments, all of those things, you have it. But if you don't, then that really impacts you. So you have to rely on transportation perhaps on your perpetrator or the person that's abusing you. Lack of transportation, services difficult to reach, they're not in your area, you might have to drive a lot, or you don't have access to public transportation. Lack of working telephone or access to services, lack of privacy away from the person that's abusing you or children to reach services, and inability to seek healthcare due to shelter curfew times and shelters not accepting children. So health inequity. Health inequities are differences in health statuses or in distribution of health resources between different populations arising from several conditions, including like where we grow, live, work, and our ages, often caused by systemic, avoidable, and unjust social and economic policies and practice. They are unfair and can be reduced by critical stakeholders. Health inequities often results in health disparities. So some of the health inequities that I thought would really be important, especially because we're talking about health, just a reminder, if some of you are not aware of some of the history that really impacts our populations, the indigenous and native communities that were really the boarding school history, which killed the Indian and saved the man. That was just has had reverberating consequences, which we're still dealing with to today. The Latino community, eugenic laws to sterilize people of reproductive age deemed unfit and defective, but they were in effect from 1920s to 1979, close to 1980. The contraceptive pill experiments, I don't know if a lot of people know that they were experimented on women, Latina women. The LGBTQ plus community, lots of issues with just respect to that community, lots of things that happen with like electric shock therapy, sterilization, conversion therapy, lobotomies, etc. Then we have the Black and African American communities, abuse of their bodies for scientific research and medical advancements, dating back to the times of slavery. Obviously, the Tuskegee syphilis study, which is just kind of, it started in the 1932, it ended in the 1972 due to public outcry, not necessarily because the doctors thought that there was anything wrong with that. So those are the kinds of things that our communities carry that I know I carry with me. So health disparities are particular types of health differences linked with unjust social, economic, and environmental disadvantages, kind of like what we just reviewed. That are systematically experienced more significantly, and they create more obstacles for obviously disenfranchised communities trying to seek care. They're preventable. Differences that populations experience and the burden of disease, injury, violence, or opportunities. Reduction in health disparities can lead to progress towards health equity. And so these are some of the examples of health disparities today present within domestic violence, traumatic brain injury, and CTE population. And just an overview, we talked a little bit about them in the first webinar and a little bit about them in the second one. But just again, women and racial and ethnic minorities are at greater risk for traumatic brain injury. Children, there's longer hospital stays, longer just ability to get care once you're there, have an increased risk of inpatient mortality, fewer procedures during hospitalization, have lower rates for referrals and rehabilitation. They also have longer waits in the emergency department. So just a lot of things that are happening in regard to health disparities in some of our communities. So then I also want to talk a little bit about intersectionality, because that also helps explain some of the things that are happening within the domestic violence population. And it's a theory that helps us understand a little bit more about that. And I wanted to just really highlight that it's Kimberly Crenshaw who really introduced us to the field. And I don't know if a lot of people know that she actually did work within the shelters in LA. So when she talks about this, she's actually talking also about women with disenfranchised women that are abused in the shelters. So I thought that was really interesting for you all to know. But intersectionality and dentists are not fixed or static, but fluid. And in the context of DV-TBI and DV-CTE, intersectionality can help us understand how a victim and survivors' unique identities shape their overall experience of abuse. So these are some of the factors, and I know I didn't say that in the beginning, but this is a very issue that's very near and dear to my heart. These are some of the things that I'm looking at as I'm working with other stakeholders across the world on what happened to my mother's case. But some of the factors, of course, age, religion, disability, migration status, immigration status, sexual orientation, acculturation, fear of deportation, the violence stigma, domestic violence stigma, distrust of law enforcement, immigration status, homophobia, transphobia, and again, the lack of culturally and linguistically responsive services. So proximity of services. So you see a lot of this kind of in the social determinants of health that we talked about. But I just wanted to really touch bases on that. So where are we going? So where do people like my mother and myself go? The research is pretty consistent in this, that women cope with DV through informal means instead of formal networks in the majority of cases. Adults are significantly more likely to disclose abuse to informal rather than formal support services. Ethnic and racial minority DV victims tend to show higher levels of seeking help from informal networks, especially women who become women tend to become the facilitators to leaving, with mothers, sisters, friends, and others with lived DV experiences predominantly providing the lifeline. So think about it. Lifeline needed as well as clergy, friends, family, online resources, and neighbors. So that was the case for my mother. It took my siblings and I to finally really help her and get her out of the environment that she was on. But the research is really consistent. We tend to go to friends and clergy and others. So informal support services, as wonderful as they are, I think the only thing that I see with that is that they are not screening and they're not aware of the DV-TBI and DV-CTE issues. And so these are some of the things that are being sought also, just the complementary and alternative medicines, which are really rooted in like psychosocial kinds of things like empowerment, self-efficacy, self-esteem, and social interactions. It really helps people, like the kind mind, body, and spirit therapies. So it helps to reduce the stress, and it helps manage anxiety and depression. But I think we also have to remember that they can be potentially harmful, especially for victims who are managing to get care for their traumatic brain injury. So they could be harmful interactions. So you just have to be aware of that. Make sure that everybody in the care team is aware of what's happening, and hopefully that the individual is able to feel comfortable to disclose what are the things that they're doing. But herbs and vitamins, homeopathic stuff, acupuncture, traditional healers, energy healers, folk medicine diets, herb healers, chiropractic therapies, mind-body therapies, we already talked about that, energy medicine. I know my mother would look like a botanicas, which is kind of like herbs and vitamins, and spiritual healers. That was something that she sought out a lot. So I really want to focus on the overall system of care gaps for the DV-TBI and DV-CTE population. I keep touching up on it in the first webinar and second webinar, but I really want to focus a little bit more on this. Where are we getting care? We're not getting care for the most part in domestic violence shelters. And I wanted to share with you why, because it focused primarily on helping women just leave. And the funding is still kind of allocated that way to shelter. Very few shelters have the resources to really add more. Some of them do, and they're doing great work, but lots of them, the majority, are not. So no DV-TBI or DV-C standards of practice are currently in place in this country or in any part of the world. Brain injuries are often invisible, especially non-concussive head impacts, so they are routinely ignored. No routine DV-TBI and DV-CTE screening in healthcare or the healthcare system is happening right now. And I mean routine and standard. I mean, it's happening across the field. No brain science focus on DV-TBI and DV-CTE currently. Minimal to no DV-TBI and CTE policy or legislation to allocate resources to address service gaps. I have yet to see it. No DV-TBI or DV-CTE brain banks really focusing on this population, and there's a lot of reasons why that's necessary. Intersectionality and health disparities further alienate disenfranchised communities, like we've been talking about. Symptoms routinely for DV-TBI and CTE are routinely dismissed, ignored, or unknown by healthcare, behavioral health, law enforcement, the system of care, et cetera, et cetera. Symptoms often are confused for other issues like depression, PTSD, stress, and others, including substance abuse disorders, and I've seen that too. DV-TBI and DV-CTE victims routinely are terminated for non-compliance or resistance in shelters and other programs, and I have witnessed that and have worked with my staff to share with them, you are ignoring that this person potentially has a traumatic brain injury, and that's why they're not able to come and complete classes, or they're not able to complete an intake. So lots of opportunities, no tracking, currently of DV-TBI and DV-CTE cases for allocation of resources. The CDC is not tracking that. I have yet to know of any state that's doing it across the state. No inclusive and comprehensive DV-TB and DV-CTE education and awareness campaigns going on, like they're going on for the military, those in the contact sports, and children who are in amateur sports. So there's a lot of other gaps, but just wanted to give you the picture of what is happening with this population. There are a handful, literally, of programs in the world that are providing services to the domestic violence population that are showing symptoms of traumatic brain injury, but there are a handful. Ohio, Arizona, and Virginia, and I just found out somebody in Nevada is doing it. What they tend to do is a program like in Arizona, they have a clinic that was set up and is set up for the NFL and all the kind of VIP sports people that suffer traumatic brain injuries. And they opened it up to women in domestic violence shelters across the state to be referred to get services. But the state of Arizona is very large and rural, so women have a really hard time traveling to Phoenix to get services. So very small models. There is also Ohio that is trying to do more kind of work focused on women in shelters. So their work is coming out of it. Their domestic violence state coalition. And then Canada and Australia, pink concussions, also they're more focused on women and women with traumatic brain injury and CTE that are athletes. And then Boston University and Concussion Legacy Foundation, which I work really closely with to get them to focus on the domestic violence population and really focus on brain injuries and trying to get their Unite Brain Bank to focus on this population, but very limited services. Then we think about the DV-TBI, the victims themselves, like my mother and myself. I am a child survivor of domestic violence and traumatic brain injury, and potentially chronic traumatic encephalopathy and other progressive neurodegenerative diseases just by some of the stuff that I'm experiencing. But, you know, if we don't know what's happening with us, then we don't know how to even advocate for us. And the majority of the population doesn't know what's happening. So we're not seeking care. We're not seeking services. And for the few of us that managed to get care, like I managed my mother to get care, I was completely dismissed, just completely. And my mother was undiagnosed. Wrongly diagnosed. So what does this mean for victims and survivors of TBI and CTE? We are unaware, undiagnosed, untreated, isolated, unable to participate or complete services, including behavioral health, legal proceedings, mental health support, shelter, behavioral health, anything you want to put there. We're just not able to complete it. Many end up being chronically homeless. And that's, we share shelter stay is not long enough to recover from TBI. Most of the victims are never routinely screened for, like we talked about. We're not being served at all. 80% of women with children who are experiencing homelessness are previously DV victims. 50%, almost 60% of women experiencing homelessness state DV is a primary cause of their homelessness. And the reason this is really important is because we have such a huge issue of homelessness in the state and all over the country. And I wanted to highlight that like this. DV survivors often experiencing homelessness are under incredible pressures as they try to protect themselves and their children whilst also achieving housing stability. But it also poses great dangers. Homelessness places DV, TBI, and CT victims as survivors at an even greater risk of experiencing further head trauma due to the level of violence on the streets, including victimization by assault and substance abuse-related injuries. So I asked myself, you know, what are the implications for the domestic violence population? What are the implications to all of us and all of you who have been hearing this webinar? And I'm, again, so thankful to all of you. And I asked, you know, myself, from the microcosm of my family story, I wonder and ask myself if TBI and CTE are critical underlying factors perpetrating cycles of violence, specifically in DV. How does DV, TBI, and DV-CTE shift how we develop future intervention and prevention strategies? What does behavioral health, first responders, and other providers advocating for TB victims and survivors need to know about the connection and correlation between TBI, CTE, and domestic violence? And these are questions I'm asking. I don't have all the answers. I just have a lot of questions. I do believe that behavioral health services and providers and the profession has an opportunity to work together to address this TBI pandemic, DV-TBI pandemic. There's an opportunity to serve populations like myself and my mother and others. We do have an opportunity to reach health equity, where everyone has a fair and just opportunity to attain the highest health of health. This requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, healthcare, and reducing and ultimately eliminating disparities in health and its determinants that adversely affect excluded and or marginalized groups. We don't have to do it all. We can start slowly. So we could start with just looking at TB screening. What do our screening assessment tools look like? Can we add questions about brain health? That's one thing. Then the CTE, the same thing. Training like this. I love that we're doing this. This is amazing, just to bring awareness. What can we do now? And because we talked about traumatic brain injury is considered a chronic condition and literally just recognized by the government last year in 2024, meaning that it's not enough to, as you've heard in webinar 1 and 2, once you have a traumatic brain injury, your chances of getting another one are pretty high and significantly high. And specifically for the domestic violence population, you are suffering from repeated head impacts. So you cannot just rely on going and getting care one time. It's not an episodic event. It is a lifelong issue because the long-term or secondary symptoms show up years later, especially when we're talking about non-concussive impacts. Those take up to 10 years sometimes to show up. So we need to look at it as a lifespan kind of condition that we're tapping into. Hey, how is your brain doing today? Are you showing symptoms? These symptoms now, are they showing up now that you had, I understand you had the last TBI when you were 20, but now you're 30. Let's see if this is happening. What are the symptoms that are showing up? So then we have a community-based strategy and pillars that we can start looking at. I'm sorry I'm going so fast, but there's a lot of material to cover, and I just want to make sure we discuss how we can address it. So the strategic pillars, if you look at it as a community, there needs to be education and awareness, inclusive and equitable strategies, discipline-specific training. I realize that nurses and child health workers and the profession in the behavioral health field needs to be a little different. So multidisciplinary, multifaceted. The training needs to be different. Sorry, excuse me, I'm jumping with my words. Brain science focus, community-based, must be community-based, research-based, standards of practice need to be developed, screening and assessment tools, elevate DV conversation, coordinated integrated care. And I'm sure you're thinking of other things that we could do. So there is policy that we have about traumatic brain injury. There's a Traumatic Brain Injury Act, but it does not address DV-TBI. So all the traumatic brain injury associations in this country, they're more, if you call for services, it's for more generic issues, meaning car accidents and other sports accidents and kind of like that, but not for the DV population. So there is lack of sensitivity to that. The Violence Against Women Act, which we've been talking a lot about, really is primary focus is housing. They have yet to talk about how we're going to address TBI. I'm hopeful that they will, but they're just not there yet. There is some successful legislation we could look at that has passed, especially when it pertains to athletes in sports. All 50 states have protocols on what to do with children who've sustained TBI as they're playing sports. And then we talked a little bit about brain science, really need to focus on this. Brain banks needing to focus on this population. How many concussive hits lead to progressive neurodegenerative diseases? How does a woman's brain and a children's brain and a youth brain look different when they have CTE and TBI from a male's brain? What medications can be developed? What treatments? What biomarkers? How do we disrupt this progression of this disease? Ultimately, it starts with having, and I believe after doing this for so many years and just privately, this is my belief, and I am always up to having great discussions, and I'm constantly looking at new information, but I do think that it begins with us having more courageous, deeper, and more honest discussions about what domestic violence is. I'm having those, and I'm having to really disclose very private aspects of my life because I think people don't know what's happening, so that we can really get at the cause roots and develop better solutions. But we have to develop better solutions together. It cannot be in isolation of each other. So now I want to open it up to Q&A. I want to thank you again. I know it's a lot of material to cover, but I really want to make sure we allocate the due time to questions, comments, anything you are thinking about or thoughts that you had during the presentation. So I will now stop.
If you have any questions, please write them in chat. Dr. Roslin commented, great presentation and information that will assist me in informing the care and consideration for members I serve. Thank you so much. Valuable information.
Wonderful. Thank you, Dr. Russell. I'm so happy to see you being present again. I'm so happy it helped. Sure. Okay. So, okay, Dr. Roslin, I see. I would love to have you come to speak trained providers who are DV providers. May I have your contact information? Okay, absolutely. Charmaine, how do I get that to Dr. Roslin? Because I believe you asked me last time, Dr. Roslin. Or Max, how do I get that information to her?
I can send out an email for you. I could connect you.
Perfect.
I should have Dr. Roslin's email on file.
Perfect. Dr. Roslin, I will provide you with my contact information, and I would be happy to do that. Absolutely. So I would like, thank you. I would like to share a little bit about what I'm doing in the country and hopefully all over the world. One of the things I'm very focused on is working with Boston University CTE Research Center, because I believe it's really critical for them to reach the domestic violence population. They don't know the risk of facing, so they don't understand the importance of brain injury. So they are putting up in their website, they're putting up a web page and really now strategically looking at this community. So if you're interested in this issue, I would encourage you to look at periodically at Pamphila or their website to get information, because they're going to come out with really a strategy on how to encourage the domestic violence to donate brains. So the reason I'm excited is because they are the world leaders on CTE and TBI. So I'm very excited that they're going to be doing that. The other thing I'm focused on, a huge effort in Washington State, because of my personal story and because of the work that I have done. And I speak for myself and based on the experience I have and the work I have done. The way we are going to really make an effort or really move forward with domestic violence in really eradicating it, which is my dream, and really prevent and do interventions, is to really serve the entire population, meaning the women, men like my fathers with abusive histories, children and youth like myself and my 6 siblings. So in Washington, we have amazing change agents. We just had our first meeting of conveners all over the state, where we talked about how do we as a state begin to identify, meaning screen, all the domestic violence population for traumatic brain injuries, and which includes the concussions and the non-concussive head impacts. How do we screen them to get them coordinated care across the lifespan? So as you can imagine, just the fact that we're having a convening, it's unprecedented. I've never been in a convening where everybody comes together. We had legislators, people from law enforcement. We had child welfare present, Casey Family Programs and the Casey Family Foundation there, other key stakeholders. We're having another convening with legislators. So, and I want to share that with you because I believe that there are other people that see, and other providers, stakeholders, that probably would really welcome the opportunity to convene and really have discussions about how do we address this for the entire, all the cohorts within the domestic violence population. I don't want to be ignored. You know, I'm a child survivor and I want to get services. So anyway, I'm very excited about what we're developing there. So lots of opportunities there that I hope it seems like we're really going to go to the next steps, and our goal is, once we have everything we're doing there, our goal is to also share best practices, lessons learned with other states, anybody else who wants to embark on the same thing we're doing. Any comments, any questions? So Alex, I thank you so much for that. A client shared with you that they had early childhood head injury, but I don't know where to direct them. I would recommend, if you don't feel that you can screen, which, you know, absolutely, please do not screen if you don't feel that you can. I would recommend, if I'm assuming that they're an adult now, if I'm following you correct, California does have traumatic brain injury clinics. I know that there's a few, so I would refer them to a traumatic brain injury clinic. And then just, I would also encourage you to educate them a little bit about traumatic brain injury, and that symptoms take years sometimes to show up. And then to really be prepared for the appointment, to write the history of traumatic brain injuries, what kinds of injuries he can recall or she can recall, what types of symptoms that they had. If you think that they need somebody to help them because perhaps their traumatic brain injury is really impacting their capacity to think or write or something, I always recommend for them to take a confidant, a really good friend, so that they can really advocate or ask questions. I would also encourage you to have them write questions that they might have for the doctor. Because, you know, when you have a traumatic brain injury, it's just a little bit harder for you to think. Take a notepad, you know. So those are the kinds of things, Alex, I would recommend. They're an adult now. Perfect. I got you. So I hope that helps. Dr. Rawson, are there any opportunities locals? You know what, Dr. Rawson, I am trying really hard to get California to really look at the issue, and I am having some good luck, and I will keep Charmaine, Max, and everybody informed. So if we start having those meetings or those convenings, you are all going to be hopefully invited. Or if you and I stay in contact, Dr. Rosalind, I will keep you apprised and I will invite you. Yes, Alex. Traumatic brain injuries, there's nothing right now in anywhere that could really screen for a TBI. It's really based on symptomatology. It's my pleasure, Dr. Rosalind. And Alex, any other questions you have, please feel free to ask. I'm glad you raised that. So as we're ending, since if you have questions, please or comments, please text them and chat, send it through chat. But I did want to just, as we're ending, highlight that brain science, when it comes to TBI and CTE, is really moving forward a lot, but not probably fast enough as I would like, right? But it's really important to, if you're going to be focused on this issue, I would recommend that you really stay apprised of it. A good place for you to stay apprised of it is Boston University CTE Research Center or Boston University CT Center. They have the latest research that they're putting out. Again, Dr. Ann McKee and her team are the trailblazers in this field. So they keep the public really apprised of the journals that they're publishing, the studies that they're involved in. And so it's just really important to stay really informed of that language if you're thinking of doing any adjustments to how you're looking at the population or your department is thinking of doing anything. It's really important because one of the things that they continually are moving towards, it's really saying that it's these non-concussive head impacts, literally, that are directly linked to progressive neurodegenerative diseases, which again, as I share, is not just CTE, it's Alzheimer's and Lewy body disease and ALS, all these other kinds of diseases. So I think that's going to be, reverberate through the entire field of the progressive neurodegenerative diseases, because Alzheimer's has yet to really talk about the correlation between brain trauma and Alzheimer's, because Alzheimer's does have a genetic form of that disease. But I just wanted to just let you know that if you were like, where do I keep up with this information? Absolutely. The brain injury, the Boston University CT Center. And then in my website, as I'm coming up with collaborations and other things, we try to keep up with the latest information and latest stage or latest providers or anybody within the system of care that is looking at this issue. I'm posting it, so if people are in that state, they can access it quickly. So anyways, just trying to share resources and information that might be helpful. I think we have a minute, right? Again, I just want to take the time to say thank you so much for being present. I appreciate you hearing the webinar series. Again, I want to thank the Academy, again, Charmaine, Max, and the others that were here but are not present. I just want to thank you profusely for creating awareness and education about this issue, and I hope that it has motivated you and inspired you to take the next step and do something within your area. And if you can, at least you've been aware now, and I'm hoping that you will be much more informed as you provide services to the men, women, and children and youth potentially that you're serving. So thank you for allowing me to do this webinar. I'm so honored and so humbled.